Ladies and gentlemen, I would like to thank both Tim Greenwich and Jérôme Bancael to have invited me today. It's a great pleasure for me to speak today and to have the honor to present to you a lecture about operational stress management in the French Air Force. After a short introduction, I will say a few words about operational stress factors, then I'll focus on ejection as a breaking point in a pilot career. Then I'll detail the role of the flight surgeon, and in conclusion, if I have the time, I would like to say a word about our conception in France between stress and trauma to articulate them with a precedent very interesting lecture. Since the French Air Force has been involved in Afghanistan, a well-connected medical system has been set up and can deal immediately with all the physical injuries and psychological conditions. The French military psychiatrist system has done its best to set the combatant in the core of this care system before, during, and after a mission. Full attention is given to the patient's mental and emotional life, to various elements in his environment, and to his personal situation in time, all of which can bring pressure to bear on his personal equilibrium. We call that a psychodynamic perspective. The feedback from our flying personnel helps us to pick up with a combination of operational stress factor, an awareness of which is necessary to understand what happened during an emergency situation. Combatants are continually facing up to questions of life and this for themselves and for others as they participate in operational mission or base activity. Briefly, three factors may be identified. Flight can be from 3 to 8 hours long. A mission could include waiting time, in-flight trailing, close air support, and so on. During such mission, airmen can be subjected to an enforced passivity. That is to say, they cannot intervene to help troops on the ground, for example. They can do nothing about the deaths which are direct result of their combat activity. Flying personnel can feel the legitimacy of their action called into question, and in the various media they see exhaustive description of collateral damage. The airmen are aware of threat from the ground and from the air during takeoff and landing. There are rocket attacks on their base. There is the risk of capture and the difficulty of surviving after being forced to eject. But on the top of that is the climate, with temperature of over 50 degrees. An accumulation of stress effects may arise from the combination of repetitive mission, concern of family life, the increased proportion of young pilots engaged on their first combat mission, and added to all of that, the normal everyday worries. The US Air Force Psychiatric Journals has proposed 4 occasions when risk is high in operational situation, taxing the capacity for both individual and collective reaction. Before a mission, a wide range of reaction can be noticed, for example an excited state or inhibition, in which the common denominator is a state of anxious anticipation. The normal combat reaction corresponds to the normal stress model, anxiety and its classical neuropsychological and behavioral association. On the other hand, the airmen may be brutally confronting with the real face of this. Accident, a member of the team killed right in front of them, an aircraft damaged and falling out of the skies, a crew being ejected, and so on. Within a few minutes, an acute stress disorder may occur and may last for several days. The mental and emotional impact of events of this kind can be assessed only in retrospect. Then, a continuous feeling of exhaustion, which appears very quickly during the 2 or 3 days of rest following an event, which can become a total exhaustion if the mission continues for any length of time. In this case, functional disorder arising from chronic stress will appear: sleep trouble, cognitive function disturbance, loss of weight, addictive behavior, risk-taking, physical complaints, and so on. Much energy is expended when flying, especially at takeoff and landing, and when flying blind. The 4th occasion suggested by Jones is that the time after an event, the time of return and readaptation to an ordinary life. It is at this time the delayed post-traumatic stress disorder. It can make itself felt, added to a feeling of shame, of avoidance. However, less than half of potential patients ask for help because they fear they will be stigmatized, which may affect their career. We'll focus on a particular event, being ejected in a hostile environment, and its medico-psychological aspect for the pilots. A pilot ejecting himself from fired aircraft is a very rare event. In France, there were 6 ejections in 2008, not any the day after, and 3 the day after. In January last year, a pilot and his navigator were ejected during an exercise in Saudi Arabia. This event is even less frequent in an hostile environment. Very few cases have been reported in the last 20 years in the literature. In 1995, a pilot and his navigator were ejected in Bosnia. They were injured while hitting the ground and immediately captured by Serbians, who kept them in captivity during 100 days. More recently, in May 2 years ago, a crew was ejected safely on Afghan territory. The 3 men were recovered by coalition force in less than an hour. Ejection in a hostile environment and fear it provokes can be understood through the feedback of pilots, especially those in Afghanistan. The whole range of anxious reaction may be observed, in fact, from the adapted operational stress to incapacitating anxious disorder. The flight surgeon should pay attention to this sign by asking the question of the possible consequences in terms of emotional and cognitive impairment. Flight safety is also at stake. Ejection is a breaking point when the pilot suddenly passes from an intense activity to a passive position in which he is often helpless and sometimes exposed to the hostility of the environment where he lands. It is always important to analyze the circumstances surrounding an ejection in order to know if the crew had time to prepare for it or not. Does the pilot ejecting following a physical or psychological incapacity, following a technical failure of the aircraft, or is the ejection a result of enemy fire? Besides the circumstantial aspects, the perception of the condition of his ejection vary greatly from one testimony to another, in fact. Some flight crews say they had time to prepare the ejection by taking time to determine where the plane were going to crash. On the other hand, others may evoke an emergency ejection, overwhelmed with fear. They report they did not have time to prepare it. Objectively, the very fact that pilot ejection was voluntary is a guarantee of some anticipation, of course. Once prepared, considered as justified, especially in the case of an engine failure, the ejection can be experienced as a successful ejection. Other pilots, on the contrary, may experience a feeling of guilt for having broken the machine, sometimes causing soul searching. Survey results, where the human factor is regularly in the foreground, are likely to reinforce this feeling. Some clinical observation allow us to understand the psychotraumatic potential effect of this brutal experience. Indeed, some pilots report an experience of intense fear related to the anticipation of the violence of the ejection mechanism, which serves injury or death as the only prospect, in a time when urgency is paramount. We can then observe the paradox of a procedure intended to save life, but which may confront the airman to near-death experience specific of psychological trauma. When it predominates, the fear of ejection can then hide the problematic related to survival in an hostile environment in the mind of flying crew. Can the flight crew be psychologically prepared for this ordeal? During training, testimony are provided by fusilier commandos on survival after the captivity, torture, and resistance to interrogation. However interesting this feedback act, we have to put into perspective the idea that there could be a preparation against potential mental trauma, because it is always a singular event, a singular experiment, on a case-by-case basis. No psychological reaction to such a situation can be modeled with a view to predictive psychotraumatic disorders. What is the role of the flight surgeon? The flight surgeon is the most important person in this operational environment. He often observed or hears of change in the emotional and behavioral disposition of their crew, and in many situations, he is the first medical provider to recognize an crew member's need for mental health care. He has to think in terms of individual and collective safety, and of the maintenance of operational capability. Here too, we could distinguish different critical occasions before, during, and after a mission. There are several different elements involved in mission preparation. For example, individual and collective operation training with team building, pre-combat fitness training, training designed to maximize an individual potential. There is also the program aimed at maximizing overall health, medical investigation to confirm combat readiness, medical briefing, and at the end, all important psychosocial preparation for flying personnel and their families, contact with spouses and partners and with children, facility designed to ease the load of everyday life, provision of data of useful contact. At this stage, we should be on the lookout for any intercurrent event for any anxiety problem, whether manifest or latent, and in particular, any sign of PTSD relating to a previous mission. And for any change in the flying personnel's normal behavioral pattern, of course. An observation is indicated to spot any sign of mental emotional trouble which could endanger both the health of the mental member of the flying crew and the safety of the mission. In some cases, it may be necessary to limit temporary permission to fly or the operational fitness until a reassessment has been carried out by the medico-psychological service assigned to aeronautics. To understand the role of the flight surgeon, it's important to understand their contributions to the provision of mental health care. Providing an atmosphere for aircrew to disclose and discuss emotional, behavioral or relational difficulties, informal meeting at the operational airfield helps the member of flying crews to feel reassured that the medical and psychological support is available and can be trusted. Skillful asking questions and evaluating conditions that indicate organic or functional changes affecting an airman's cognitive ability, concentration, attention, reasoning, memory. Recognizing when a formal mental health evaluation and intervention is needed. Flight crew affected by a potential traumatic situation should receive all or full attention. Possibly a period of time out to return to normal sleep pattern is allowed to recover his ability to adapt and to adjust. It is important to reassure the pilot, to give him the time he needs. A short-term course of medication may be helpful. Hydroxyzine or fast-acting hypnotic drugs may be considered, subject to a minimum period of 6 hours before flying and to a previous suitability trial. An isolated problem with no effect on safety allows him to return to flying with close support and as part of a well-defined project in which the pilot himself is fully involved. His flight leader must also be part of this project, under condition of medical confidentiality. The flight surgeon collaborates with mental health provider to address the problems and needs of an airman. He has the support not only on the psychiatrist in the military hospital of the theatre of war and of the medico-psychological service assigned to aeronautics. Finally, the return to the home base is a crucial period. Combat personnel have been through such intense experience that they need to reconnect. They have to re-establish contact with the routine of their professional life and their daily family life. They need to feel that their commitment is recognized and it demonstrates the importance that they are reassured that once again they are part of their family. Flying personnel will benefit from a medical check and a listening ear a few weeks after their return from a combat mission. It may be helpful to suggest some non-flying time when a chronic exhaustion is felt, for example, helping to reduce such symptoms in a climate and mutual confidence. The flight surgeon has several obligations at the same time and may find themselves doubting their own ethics. On the one hand, the medical officer is responsible for his patient's state of health and for their combat readiness. But at the same time, on the other hand, he has a more general responsibility for pilot flying competence as well as for air safety. Because the medical officer is familiar with Air Force personnel, operation and organization is able to balance their conflicting needs. The medical officer really has the ability and the fact that he is continuously engaged in gaining the confidence of those in his charge are the key of successful medico-psychological support in theater of war. At any time, he can call for help and advice from the psychological service of the aeromedical center. If I have the time, I would like to say any words about our conception about differences in stress and trauma that we have in France. The notion of stress and trauma, in fact, are by no means equivalent. A second event experienced by numerous individuals will only be traumatic for a few of them. However, the same traumatizing event can lead to a trauma in two controlled subjects, the time of the flashback will be different. Question is why? The condition and possibility of the trauma are established by genetic and psychological determinants, which are interactively integrated at the heart of a social context. Non-numerical study has revealed a biological marker, which would apparently inevitably destine a subject to structure a PTSD in reaction to a stress. In contrast, the psychopathological study discovered afterward that a particular subject had necessarily built a traumatic repetition syndrome with flashback according to the concordance of significant data relating to their history. The traumatic event, strike a repression or an autobiographical deadlock of which the thematic question the fundamental for human culture and its emancipation with nature. What led to a trauma is not just a stressful event in itself, but its encounter with the person who was there and who invested mentally in the scene experience. Far from being just a non-specific biological reaction of the brain to stress, the psychotraumatic response is also the result of the subjective psychic implication of the subject. Thank you very much for your attention.